I would now like to invite Dr. Shweta Agarwal. She'll be speaking about how the solution to some situations lies within and the use of tenonplasty and Tenon's patch graft for corneal perforations.
A very good evening. This is really an interesting session where probably we are trying to seal the cornea with everything possible and just giving you many options. There is no best option, but it's, the best option for your patient at that very time with whatever we have. So the solution lies within Tenon's patch graft, when and how. I'm Shweta from Shankar Netralaya. So for an ideal substitute for a corneal perforation has to provide a good tectonic stability, should be easily available, and should be affordable. Well, the concerns that are present, that are with the present options available, cyanoacrylate glue is extremely good with perforations which are less than 2 millimeters. A multi-layered amniotic membrane, we are not very sure about the tectonic stability that can provide. It can be used for a persistent epithelial defect with an early melt. And corneal and scleral patch graft, you always have a concern with as far as the tissue availability is concerned.
He has to sign the attendance.
Now, why Tenon's? Tenon's capsule basically has the anterior and the posterior aspect of it. The posterior Tenon's is just a condensation of collagenous fibers. However, your anterior Tenon's capsule is made up of collagen, elastic, and smooth muscle fibers. And the rationale behind its use is basically it produces autologous fibroblast and connective tissue, which provides a structural support, reduces inflammation, and accelerates wound healing. Where the use of Tenon's was first proposed by Dr. Vajpayee et al. And from then on, people have been using Tenon's in multiple indications. When to do? Most commonly, it is preferred that you do it in patients with autoimmune disorders. In infectious keratitis, the results have not been very encouraging. The size of the lesion that you can manage with a Tenon's patch graft is somewhere between 3 to 6 millimeters. Well, how do you do it? You can anchor it using a fibrin glue. You can use stay sutures, a 10-0 or a 9-0 nylon interrupted sutures, or an overlay suture. And in larger grafts, you can use the sutures and use cyanoacrylate glue at the edges. Just a small video to show how we do it. So you just mark the edge a little beyond the area of involvement, trephine it with, so that you have a regular trephine, 0.5 millimeters larger, go a full thickness into the area of the harvesting that you are chosen from, cauterize the underlying bed. This fibrin glue can be anchored using, the Tenon's can be anchored using a fibrin glue and then with interrupted 10-0 nylon sutures. The donor site is approximated using a cautery. And since this was a patient of Stevens-Johnson syndrome and we were worried about epithelialization in this eye, we have just applied a thin layer of cyanoacrylate glue over the surface and placed a BCL. A small, simple procedure, but at hand and of use, especially in eyes like this. Thank you.
Thank you, Dr. Shweta. I think that was really cleared all the concepts. Any comments from the panel?
Yeah, Tenon's patch graft is a very useful technique. It's autologous and certainly a technique which everybody should be familiar with. It's very useful.
Yeah, I think we should be all grateful to the AIMS group for bringing it forth. It's a beautiful technique. Beautiful technique back. And something, Sundar Sasta Tikau, always available.
Now, only my one question that on top of it, you put cyanoacrylate glue.
So in this patient, because
this patient, not in all patients.
No, so this patient was a case of Stevens-Johnson syndrome. And when this surgery was done by one of my fellows and he was not very comfortable, he was not very...
sure about the leak part.
No, not the leak, sir, the conjunctival epithelium. So when we stained the Tenon's graft, we had in fact harvested it with the conjunctival autograft, but the handling of the tissue was not as good as it should have been. So it had an epithelial defect. And because this was a patient of Stevens-Johnson syndrome, we didn't want to take any risk. So which is why we applied a thin layer of cyanoacrylate glue over it.
Madam, I have a question. How thick do you want the Tenon's patch to be?
So
sometimes, you're harvesting, you have a doubt how thick you want it to be. Your comments on that?
So it depends again on your host bed. And most of the cases what happens is you have a central small area of perforation and your periphery is still okay. And if you don't put adequately, that area is going to leak. So like, your cystoid cicatrix or your desmatocene. So what we prefer, like we did in this patient, is you take a small trephine of 3 or 4 millimeters, you mark a ledge, and like you do an LK, so in the peripheral part of that area, you do a lamellar dissection. So you have a good host bed, and then you take a full thickness bunch of it, so that the central part where there is a perforation, you have an adequate tissue, and the peripheral part you have already made a lamellar bed, so there is no bulge or and the surface is flushed. So
And continue to that question, that which site is you get the thickest tenon, which quadrant or which clockwise? From practical experience in young, we know that old patient you do not have any prediction, but young group,
usually
which
the fornices, I think, are good enough.
now which side of the fornix?
The-
Temporal, nasal? Now I'm just asking.
Yeah,
I do
no,
not
so
know. Long time I have not done it.
No.
So
I get your point. Dr. Basak, and this is actually a very important question. So usually the temporal inferior half would be a good place to harvest your conjunctival, your Tenon's graft.
That is the bulbar part of
The bulbar,
and
the
my
fornical bulbar.
another comment is, I have learned one thing. I mean, relearned rather, that everyone showed your videos that sharp edge is different techniques are there. You have taken a punch, trephine, they have taken, someone is using the blade, but that is one of the important step. Not just that is a perforation, you put either a patch or tenon or whatever, but you have to give a clear margin with a sharp edge. That is one of the important factor, because the bed, there are some residual corneal tissue in that area that will help to anchor whatever you are putting over it. Otherwise, there will be leak.
Yeah, so absolutely. If you don't have a good graft host junction approximation,
This is
even
for
the
you.
epithelial healing is going to be an issue. It's just like doing any LK or a PK suturing. Your epithelium is not going to jump. So it has to be very smooth. So, Dr. Basak, the point well taken.
Madam,
Because
my
the juniors are there. Yes, one question.
Infectious keratitis, if there is a perforation, if this works, it's a disease.
So, sir, we are honestly not very happy using a Tenon's in case of infectious keratitis, and whatever literature I did go through while making this talk as well, they have not had encouraging results with Tenon's. Multiple reasons. One is the entire area is very necrotic. So, anchoring this Tenon's also is going to be difficult. Underlying the Tenon's, you won't be able to see what is happening to the tissue. So in infectious keratitis, my bet would still be, if it is a smaller perforation, I would still go for a cyanoacrylate glue with a BCL. And if it is a larger perforation, a patch graft using any of the other tissues like cornea or sclera. Anything else that?
Yeah,
No, absolutely, you are absolutely
the technique of suturing, like many people have described, one is that you actually pass the sutures like you showed, and another is that you kind of like just anchor it over some kind of
Overlay,
mattress kind of
overlay.
sutures, like overlay sutures. Now, in these kind of situations, like especially infective keratitis or something, I mean, results in my hands are very, very good with just those kind of anchoring, compressive kind of mattress kind of sutures,
Overlay
which is
suture.
overlay sutures. So what is your take on that? What kind of sutures, even the case that you showed, I think had you put overlay sutures, I think it would have done
No,
maybe
it is
reasonably all right,
actually
or no, it
case to
wouldn't have.
my opinion, it is case to case basis. What Amit is, I fully agree. Sometimes initially, my initial years, I used to give, because I cannot pass the suture, there is cheese wiring, so limbus is clear, so take a and I used to take 9-0 suture, mind that, not 10-0, 9-0, you have a very good tight, so you
I
give
think that's
like
a nice step using a 9-0 suture.
Correct.
so
He'll give more
like
strength,
a
tension.
mesh, you are creating a mesh over tenon.
Correct.
And in full
So,
thickness
and
perforation,
later
it
on
does
you
very
can
well.
remove very
extremely well.
early.
It
Very.
heals so well, because to pass sutures through tenons is very, very tedious.
Tenon is tedious, and also if it is necrotic, like viral keratitis. So you go beyond, then you get actual good stroma, then you can pass. Before that, there will be cheese wiring, and your surgery will be more messy.
Correct.
Right.
So overlay suture in those cases
Overlay
is
with the 10-9-0.
9-0, you get good strength actually. You, like tightening of the suture, It is very good. Chalo,
Thank you
very
so
good
much.
discussion, Shweta.